Welcome dear students. In the previous video, we have learnt about various types of hearing loss. If at all the defect was present in the conducting system right from the external ear to the inner ear up to the cochlea, we said it was conductive type of hearing loss. And beyond that we called sensory neural type of hearing loss, and that could have been because of a lesion in the cochlea or even beyond, like in the eighth nerve or in the central auditory pathway. Central auditory pathway right from the brainstem up to the auditory cortex. So based on the location of the lesion, we classified hearing loss into various categories. But now we are going to learn about a totally different type of hearing loss called as non-organic hearing loss or functional hearing loss. Now the characteristic feature of this hearing loss is that nowhere in the entire system, either anatomically or physiologically, a lesion is described. There is no lesion that can be found out. In the entire pathway, there is no anatomic defect or no physiological defect, but still the patient complains of hearing loss, and such hearing loss is called as non-organic hearing loss. Non-organic hearing loss, in short NOHL. It's also called as functional type of hearing loss. And what is the most important feature? No demonstrable lesion, either anatomically or physiologically. Nowhere in the pathway there is a defect that can be demonstrated. There is no organic lesion. Now, when there is no lesion anywhere, why would the patient complain of hearing loss? There are two possibilities. One is the patient is malingering, or second, it could be psychogenic hearing loss. Who is a malingerer? A person who feigns illness to get some benefit. So, it could be a malingerer. Or second, it could be psychogenic hearing loss. Generally, psychiatric problems cannot be demonstrated anatomically or physiologically. No lesion can be demonstrated in psychological problems. But in non-organic hearing loss, it is mostly a malingerer. Very rarely we find a psychogenic patient who complains of hearing loss. Usually it is a malingerer. Why do people feign deafness? To get some benefit. As we have learnt, noise-induced hearing loss and some occupation-related hearing loss, they are eligible for compensation from the side of the employer. Or to get some other benefit, to claim some benefit, a person might, to claim some benefit, a person might feign deafness. To claim some benefit. So, a malingerer might present with total loss of hearing in both the ears or total loss of hearing in one ear, or sometimes they could have some hearing loss but they exaggerate that hearing loss. So, any of the presentations are possible. Now, suppose the patient is working in some company or factory that produces a lot of noise. It is possible that he is actually suffering from noise-induced hearing loss and he wants a rehabilitation or a change in his job. Or it is possible that he do not like his job for some other reason, and claiming hearing loss, he wants a compensation or he wants to change his job. That's possible. Now, why would somebody exaggerate hearing loss? It is because even hearing impairment comes under the reservation for physically challenged people. Hearing impaired people do have some reservations under some government schemes, or they are also beneficiaries under some government schemes. Now that benefit they receive depends upon the amount of hearing loss. If at all, if it's a very mild hearing loss, sometimes they do not receive any benefit. If it is moderate hearing loss, they might get some hearing aids. Only if it is a severe type of hearing loss do they get a reservation or some other compensation. So for that purpose, it's possible that they could be having some mild hearing loss and they try to exaggerate that hearing loss to get a better benefit that they desire. So these are various possibilities about malingerers. So it's important that we identify a real victim of hearing loss and also identify a malingerer. Either ways, we must not drift away. So our first question to ourselves when a patient presents with hearing losses, is the patient a malingerer? We have to find this out first. Second question is, what is his actual threshold of hearing? Now, it's not that for some reason you believe the patient to be a malingerer and you send him away. No, we have to actually measure the threshold of hearing. Because as I said, he could be having some hearing impairment. Although he is exaggerating more, he could be having some hearing impairment. So, we must find out what is the actual threshold of hearing. So, to answer these questions, as a doctor, first, we must have a high index of suspicion. How do we get this suspicion? First, by having knowledge about this entity called as non-organic hearing loss. And second is, these patients, malingerers, exhibit certain traits of behavior that are very typical to malingerers. For example, when a patient comes to you with hearing loss, they are not very much interested in the treatment part of it. They want two things. One is they want a documentation that they have a hearing loss, a report describing their hearing loss, and they are interested about the compensation or the benefits they receive for that type of hearing loss. Even if you try to explain that this hearing loss can be treated by some surgical correction or they have to use some medication, say he's suffering from some serous otitis media, simple serous otitis media with mild hearing loss, you might say that you can prescribe some medications that will help them heal. Or whatever type of treatment you offer, even if you say hearing aids are available, they do not show much interest in the treatment. They are more interested in getting that document. And second is, they try their best to convince you that he or she is deaf by repeatedly asking you to repeat. They say, sorry, I cannot hear, could you repeat? And they appear as if they are trying their best to hear, and in spite of that, they are unable to hear. For example, I've seen patients who put their hand behind the ear, they cup the ear and try, to close their eyes and do this as if they're trying their best to grasp what you're saying, but still they are unable to hear. Now, every person who cups his auricle is not a malingerer, but these are some traits that are seen which should arouse a suspicion in you as a doctor. So, we must have high index of suspicion. Looking at the behavior of the patient will give us a clue. Second characteristic feature that is seen with malingerers is, now even in spite of getting a suspicion, we will not leave the patient, right? We will perform some investigations. Usually we do a pure tone audiometry. And when you repeat the test, the results are very, very different. They vary. So, inconsistent results. Inconsistent results on repeat pure tone audiometry and speech audiometry. Why does this happen? Because the patient is lying. When you are performing pure tone audiometry, he is actually able to hear, but after some point he decides that I have to show hearing loss from this point onwards. So he says, I cannot hear, I cannot hear, I cannot hear, and you plot the same thing on the chart. And 2 days later, again, say he goes to another doctor or he comes to you and you perform a repeat test. He does not remember exactly from which point he decided to appear deaf. So next time the results would vary. He would decide at some other point that he will stop hearing and he will say, I cannot hear. So say today when you perform the test, he is suffering from 30 decibels hearing loss. Again when he comes, he could have 45 decibels hearing loss. And 3 days later, again if you perform the test, there is only 10 decibels hearing loss. So it's possible various results appear, varied results appear, inconsistent results. Now, in a normal patient also, a genuine case of hearing loss also, there is a variation of 5 decibels. Now, if you repeat pure tone audiometry in any person, the exact chart you might not be able to reproduce, nor will the patient be able to give the same result. 5 decibels plus or minus is acceptable, and it happens, it is normal. But if it is more than 15 decibels variation, then it points out towards non-organic hearing loss. 5 decibels is normal, but more than 15 decibels variation, it is non-organic hearing loss. Next, what we observe is there is something called absence of shadow curve. We have already learnt about this in pure tone audiometry, but a quick recap. What is a shadow curve? Now, the hearing impulses are transmitted from one ear to another ear transcranially. So, even if the person is absolutely deaf in this ear, beyond a particular point, the impulses from the opposite ear are picked up and the patient says, yes, he can hear. And you plot the same on the pure tone audiometry chart. So, what he is able to hear is actually from the opposite ear. This ear, the deaf ear, is not able to hear anything, but the impulses are being picked up. They are going transcranially to the opposite side, and the patient can hear something. And falsely, we mark those levels, and the actual hearing loss is not picked up. A shadow curve is obtained. Say, suppose there is 80 decibels hearing loss in this ear. Repeat. Say, suppose there is 90 decibels hearing loss in my right ear. And when I perform the test, up to 40 decibels the patient cannot hear anything. From 60 decibels what happens is the opposite ear picks up and the patient says he can hear, and we plot the same thing. So we assume that he is just having some 40-50 decibels hearing loss. This is all the problem because of this transcranial transmission of sound impulses. And to avoid all this, what we do, we perform something called as masking. The non-test healthy ear is given some narrowband noise so that it cannot pick up, it does not respond to the sound impulses that are being given to the test ear. We perform masking. If at all masking is not done, you get false results, and those false results on a pure tone audiometry chart are called as shadow curve. So to avoid shadow curve, normally what we do is we perform masking. Now in a patient of pure tone audio, Now in a patient of non-organic hearing loss, when we do not do masking and we are checking the so-called deaf ear, after a point, the opposite healthy ear should be able to pick up the sound impulses and the patient should say, yes, I am able to hear. But because he is deliberately saying he cannot hear, even though the sound is being picked up by the opposite ear, the patient says, no, I cannot hear anything. So, a shadow curve which was normally supposed to appear because of the opposite healthy ear, that also does not appear in this patient. Though you do not mask the opposite healthy ear, the patient still cannot hear anything, and so there is no shadow curve. So, in spite of non-masking, the healthy non-test ear, there is no shadow curve. In non-organic hearing loss. Next, the next feature is there is some inconsistency in pure tone audiometry and speech reception threshold. Let us see how they both correlate with each other. SRTS, speech reception threshold. Normally, when we do a pure tone audiometry, we can predict the speech reception threshold because it is within 10 decibels. The pure tone audiometry and speech reception threshold are within 10 decibels to each other. Now, if at all the speech reception threshold is better than pure tone audiometry by more than 10 decibels, it indicates a non-organic hearing loss. Normally, the pure tone average of 3 speech frequencies. Pure tone average is calculated by taking the average of 3 speech frequencies, which 3, 500, 1000 and 2000. This is within 10 decibels of speech reception threshold. If the SRT is better than speech reception threshold by more than 10 decibels, it points out towards non-organic hearing loss. This is another way. Next, we have a very interesting test called as Stenger test. Now, this test I sometimes feel has been invented to catch hold of malingerers. Okay, it's a very interesting principle and concept. So, pay attention and listen to me. It runs on one principle. First, let us see that principle and then we will see how the test is performed. Now, the principle of Stenger's test is that a tone of two intensities. Two intensities means one intensity is greater than the other intensity, is delivered to both the ears simultaneously. Only that ear which receives greater intensity will be able to hear it. I will write this down and explain in detail. A tone of two intensities one greater than the other a tone of two intensities, one greater than the other, when delivered to both ears, only that ear which receives the greater intensity sound, only the ear which receives greater intensity sound will be able to hear it. This is the principle of Stenger's test. For this, what we do is we use a pair of identical tuning forks. Identical tuning forks in the sense, tuning forks with the same frequency. Two tuning forks, both of which have 512 Hz frequency, let us say. Or both of them have 256, something like that. Identical frequency tuning forks, we take two of them. Now, let me explain the statement. What does this mean is, you take a single tone, one tone. You select say 512 Hz tuning fork. Tone means it is related to the frequency. Tone is about frequency. It is measured in Hertz. Intensity is about the loudness. It is measured in decibels. They both are two different things. Tone is about frequency and intensity is the loudness of sound. Okay. So, you take a single tone at two different loudnesses. One is more loud than the other. Okay, say one is at 20 decibels volume, the other is at 30 decibels volume. And you present that same 512 Hz sound at two different volumes to both the ears. The principle of Stenger says that only that ear which receives the higher volume sound, greater intensity sound, louder sound will be able to perceive the sound. 512 Hz tuning fork I put at both the ears. This I put it very close and this I put it far. So obviously this is louder. And only this ear will be able to hear that sound now. This ear cannot hear anything. That is the principle of Stenger's test. Is the principle clear? Yes. So let us see how this test is performed. Now first I will take a normal subject and explain the principle again. This is our patient. We have to blindfold the patient. The patient cannot see anything, he must only answer our questions. And you have taken a tuning fork of 512 Hz, identical tuning forks on both the sides. And this side, you put the tuning fork here. And this side, you put it close to the patient. Now, what will happen according to the principle of Stenger? You put identical frequency tuning forks at different distances to alter the intensity of sound. Now, the intensity of sound is greater on this side, the side where the tuning fork is closer to the ear. So, when you ask the patient which side are you able to hear, according to the principle of Stenger, what will the patient say? I am able to hear on the side the tuning fork is closer to his ear. He does not know because he is blindfolded. He will just show you I am able to hear on this side. So the patient says I am able to hear on this side. That is a normal person. He can hear only on one side, mind you. Whichever side higher intensity sound is presented, only on that side he will be able to hear. He cannot hear anything on this side. Because same frequency, whichever sound is louder, only that will be picked up by the ear. So the patient says I am able to hear on the side where there is higher intensity and nothing on the opposite side. He is a normal person, we sent him away. Next comes our malingerer and let us see how he deals with the situation. So this is the malingerer. We have blindfolded him also. And what we did is, first we put two tuning forks at equal distances, equidistant. And this malingerer is claiming that he is unable to hear on this side. He is deaf on this side, on the right side. You put both the tuning forks at equal distance and he is saying he is deaf on the right side. So automatically the patient, when you ask the patient which side are you able to hear, he will say I am able to hear on the left side. I am able to hear this sound. Okay, well and good. Next what you will do is, on the same patient, in the second step, this is step 1. This is step 2 on the same patient. What we will do in the next step is, we will bring one tuning fork close to him. This side he said he is not able to hear. No, on that side we bring the tuning fork very close to his ear. Now in reality what happens is, when you bring one tuning fork very close to here, to his ear, that side sound intensity will increase. Now in reality he should be able to hear only on this side, only on the right side. But the patient is feigning deafness on that side. So he cannot hear. He cannot agree. He cannot accept that he is hearing on this side. So he will say, I cannot hear anything at all. No sound. And you will understand it is a malingerer. How will you understand it is a malingerer? Because if the patient is truly deaf on this side, okay, even if you bring the tuning fork close to his ear, he cannot hear. But what about the opposite side tuning fork? He should at least be able to hear this, right? A really deaf patient cannot hear on the right side, on his side, whatever side he complains. Although you brought the tuning fork close to his ear, he cannot hear, but he will definitely be able to hear the opposite side sound. Because he is actually not deaf in this ear, he is able to hear this tuning fork sound. In fact, he is able to hear only this side tuning fork sound, because same frequencies, loud intensity, right side has become loud now because you brought the tuning fork close to his ear. In reality, he is hearing only the right side, but he cannot agree that he is hearing on the right side. So he says, I am not able to hear anything. Because he is hearing only on right side, he is not hearing anything on the left side. Because according to Stenger's principle, only that side where the intensity is loud, only that ear will perceive the sound. So he is not hearing anything on the left side, he is hearing it on the right side, and he cannot agree that he is hearing on the right side. So he says, I am not able to hear anything. Whereas a truly deaf patient on the same right ear, although he cannot hear on the right side, he will be able to hear the opposite side tuning fork. And he will say, I am able to hear on the left side. If he says no sound at all, then you understand that it is a malingerer. This is Stenger's test. It's a very interesting concept, slightly conceptual, but I think it's understandable, isn't it? Okay. This is one test where you identify a malingerer, and instead of we using two identical tuning forks and adjusting the intensity of sound by the distance and all this, directly you can use, instead of tuning forks, identical tuning forks, this test can also be performed by a 2-channel audiometer. So in that what happens is, the patient is using headphones and directly you can adjust the intensity of sound. Just like how we adjust the sounds on pure tone audiometry, like that you select a specific frequency and you can just increase or decrease the intensity of sound. That's a more sophisticated way of doing it. But the principle remains the same. This is Stenger's test, which can be performed either with a pair of identical tuning forks or with a 2-channel audiometer. Next is, the next test is acoustic reflex threshold. Acoustic reflex threshold. What is acoustic reflex threshold? Acoustic reflex is nothing but stapedial reflex. Why is the stapedius muscle present? It is running from posterior to anterior direction. It attaches to the stapes and it contracts in response to a loud noise to dampen the sound, to protect the inner ear from loud noises. So even if the patient claims that he is not hearing, when you expose him to a loud sound, the stapes will do its job. It will contract and show the stapedial reflex. And the stapedial reflex can be demonstrated, it can be measured. So normally the stapedial reflex occurs at 70 to 100 decibels sound. At 70 to 100 decibels sound, stapedial reflex occurs. If the patient can hear that sound. If he cannot hear the sound, no stapedial reflex. Now in a patient who's claiming total deafness, he says he is absolutely deaf in that ear, but stapedial reflex is elicited. What does that mean? The patient claims total deafness, but when you are increasing the intensity of sound, at some point stapedial reflex is elicited. It obviously means that the patient is a malingerer. And it is a case of non-organic hearing loss. This is another test. And the last and final test is, now all these tests, your clinical suspicion, pure tone audiometry, There was an era when there were only subjective tests of hearing. Subjective test means the patient has to cooperate and you have to trust the patient's results, whatever the patient says. But now we have got objective tests. Irrespective of the patient's responses, we can accurately find out his hearing levels. Now, objective tests are very useful in malingerers. They are useful in infants, in small children who cannot cooperate. They are also useful in psychiatric patients or some very low IQ, mentally retarded kids. In all of them, objective tests are very useful. And finally, we have an objective test here also, which is helpful to identify malingerers, and that is electric response audiometer. Now this electric response audiometer, it's an objective test and it can establish hearing acuity of the person within a range of 10 decibels of the actual threshold. Within 5 to 10 decibels, you get the result. So this test can establish hearing acuity. Within a range of 5 to 10 decibels of the actual threshold. It's accurate to that extent. So when you perform that, there is no scope for the patient to say he is hearing, not hearing, at which point he stopped hearing. No scope for all that. You will directly check and the machine will give you the results. And it's accurate to the extent of 5 to 10 decibels. This is the final, I can say, litmus test to find out malingerers, non-organic hearing loss. So these are various tests for us to find out malingerers or non-organic hearing loss. Let me quickly repeat this entire concept of non-organic hearing loss, also known as functional hearing loss. First, we have to understand that what is non-organic hearing loss, where no organic lesion can be demonstrated in the entire auditory pathway. Anatomically or physiologically, there is no lesion anywhere, but still the patient complains of hearing loss. Why? Either he is a malingerer or he is suffering from psychogenic hearing loss. So we must find out if the patient is a malingerer or a truly hearing loss patient, and what is his actual threshold of hearing, because there are various presentations. The patient can present with complete deafness in both the ears, or one-sided complete deafness, or an exaggerated deafness. He says he can hear to some extent, but his hearing is very, very low. And it's possible that he is having some hearing impairment and he is exaggerating that hearing impairment to claim certain benefits. So what are the various tests? How do we find this out? First, having a high index of clinical suspicion. The results of pure tone audiometry and speech audiometry are inconsistent upon repetition. A variation of up to 5 decibels is acceptable. More than 15 decibels variation points out towards non-organic hearing loss. And normally a shadow curve is observed if at all masking is not done for the non-test ear. But absence of shadow curve, which is normal, is seen in non-organic hearing loss. A shadow curve is normally observed. Absence of shadow curve indicates non-organic hearing loss. Inconsistency in the results of pure tone audiometry and speech reception threshold. Normally, they are within 10 decibels to each other, but if the variation is more than 10 decibels, if SRT, if the speech reception threshold is better than pure tone audiometry by more than 10 decibels, it indicates non-organic hearing loss. 10 decibels has to be remembered here. Now here it is 10 decibels and variation on repetition of test, it is more than 15 decibels. Next we have a classic very important test called as Stenger's test. To understand the entire Stenger's test, we must understand one single principle, that when same frequency sound of two different intensities is applied simultaneously to both the ears, only that side where the intensity is greater, only the louder side is perceived by the ear. and the opposite side nothing is heard. This is normal. So how we use this in a malingerer is, first we put two tuning forks at equal distances and the patient says he is able to hear on one side. Now he selects one ear to be deaf, either the right ear or left ear. If he chooses left ear, he says I am able to hear on the right side, and if he chooses right ear to be deaf, he says I am able to hear on the left side. And the patient is blindfolded. Next what we do is, we increase the intensity on the side where he is claiming deafness. If he says he is deaf on the left side, we increase the loudness on left side so that he in reality hears only on the left side and he does not hear anything on the right side. Now because the patient is claiming deafness on the left side, he says he is not able to hear anything. Because in reality he is not hearing anything on the right side. He is only able to hear on the left side, and because he is claiming that ear to be deaf, he says he is not able to hear anything at all. And then you understand it's a malingerer, because a normal deaf person, if a truly deaf person, if he is deaf on the left side, although he cannot hear anything on the left side, at least the opposite side tuning fork he should be able to hear some sound. So he will say I am able to hear something on the other side. Only a malingerer will not be able to hear anything, will say he is not able to hear anything. This is Stenger's test. Next is acoustic reflex threshold. This is also an objective test. The normal stapedial reflex occurs at 70 to 100 decibels if the patient can hear. So although the patient can hear, he says he is not able to hear, but the stapedial reflex will do its job. The stapedius muscle will contract. And when the patient claims complete deafness on one side and you still observe stapedial reflex, it is understood that he is malingering. And finally, we have electric response audiometer, which can measure the hearing acuity in a range of 5 to 10 decibels of the true values. It's also an objective test and the final test. With this, we can identify malingerers. We can differentiate between truly deaf patients and malingerers. And this is about non-organic hearing loss. And with this, we complete all the different types of hearing loss. Conductive deafness, sensory neural deafness, and in sensory neural we have some special conditions such as presbycusis, sudden hearing loss, noise-induced hearing loss, autoimmune hearing loss, ototoxicity because of some drugs, and various other types, familial hearing loss. And finally, we have a totally different separate entity called as non-organic hearing loss or functional hearing loss. With this, we complete all the types of hearing loss. Thank you very much and have a nice day.